Hello, everyone. This is Dhiraj Gupta. I'm a consultant cardiologist, electrophysiologist at Liverpool Heart Chest Hospital, and it gives me great pleasure to welcome you to this inaugural Arrhythmia Academy Journal Review session, which we are hoping that it will be a regular session every month or every 6 weeks, in which we will review some interesting articles that have been published in the heart rhythm related journals, and we will also then speak to the senior authors of those journals to try and get an insight in research and also try to put it in context with what has happened before and the likely implications of that research going forward. So what I thought I would do this time was I started with looking at the journal Europace, and I came across this very interesting paper called Prognosis of Incidental Left Bundle Branch Block. Now, the reason why this caught my fancy was because we all know that left bundle branch block is an additional independent risk factor in patients with structural heart disease, whether idiopathic dilated cardiomyopathy or following myocardial infarction, or even in patients with aortic stenosis or following TAVR, for example. But what is the prognostic value of left bundle branch block that is discovered incidentally, just on a baseline ECG? The patient may be asymptomatic, the transthoracic echo may be absolutely normal. We know, and there have been some studies from a very long time ago, back in 2005, there was an excellent paper from Miller and colleagues which showed that even incidentally detected left bundle branch block may not have a benign prognosis. But for some reason, there's a lot of uncertainty about this. And this paper, as you will see, really tries to answer that question, and it brings this age-old problem of left bundle branch block into the modern arena by assessing through cardiac MRI. And it gives me great pleasure to welcome the senior author for this paper, Professor Francisco Leyva, my colleague from Birmingham and a senior academic there, who will very kindly spend about 5-10 minutes with us, taking us through the study, the protocol, the findings, and the implications. So welcome, Paco.
Thank you, Dhiraj. I'm very grateful to you and to Arrhythmia and to AA for allowing me to comment on this paper. So basically, as you say, this is an age-old problem, actually. This is a problem that we all come across. Patients referred for no apparent reason, no cardiac symptoms, but a left bundle branch block has been detected at some point. We get these patients from non-cardiac clinics, from GPs, and no one is quite certain about what to do. So my motive for undertaking this study is really just to answer the question as to what to do with someone with an incidental left bundle branch block. So if you look at the literature, really, we can go back to the 1950s. And of course, then there was no echo, there was no MRI, there was nothing else at all. And in fact, if you go back to studies from 1951 to 1993, and as you say, Miller was the most recent one, but even that really doesn't employ imaging. So these are just studies looking at an ECG abnormality in relation to total mortality, but certainly not mode of death and certainly not etiology. So we now have a very powerful tool, namely cardiac MRI scanning, to try and that allows us to not only quantify left ventricular function, but also to characterize the myocardial phenotype. One of the unique features of this technique is that it allows us to see scar, and it may really allow us to detail with greater precision what the underlying phenotype might be, perhaps even before the clinical manifestations are detected. In fact, looking in the literature, there was a study in 2012 by Mahmoud and colleagues in which CMR was applied to 54 patients. And that was a very useful study. It showed without a doubt that there was an incremental value of using CMR on top of echo to diagnose the underlying myocardial phenotype. However, that study had no follow-up at all. So in this study, we looked at 16,000 cardiac MRI scans undertaken in our hospital from 2010 to 2017, and went through all the diagnoses. And it was a rather painstaking approach of trying to identify patients who were referred with an incidental left bundle branch block, which we defined as a left bundle branch block identified at the point of referral in a patient who is free of cardiovascular symptoms and who have no history of cardiac disease. They may have been hypertensive or diabetic, but certainly no evidence of cardiac disease. In addition, this is a very important thing, is that we've excluded patients who had evidence of significant valvular disease, and particularly aortic stenosis, which is very relevant in these patients. So we have not looked at those patients. We've excluded them. So this is beyond aortic stenosis, which is a very important diagnosis to do and to follow up. The control group, obviously, to have a control group in these patients is quite difficult, namely because it is difficult sometimes to justify doing a gadolinium-enhanced cardiac MRI scan in a completely healthy individual. Having said that, we managed to have over 100 patients with a gadolinium-enhanced MRI scan and an ECG, which who participated in previous studies, and we used that as a control group. A left bundle branch block was defined using a relatively wide criterion of a QRS duration of greater than 120 milliseconds. So this is not a Strauss type of left bundle branch block. It is a loose definition of a left bundle branch block. So that was the study population, and as you can see from this slide, we have 110 patients who had an abnormal myocardial phenotype. So 57% of patients had an abnormality on the cardiac MRI scan. The remainder had a normal cardiac MRI scans. And as you can see from the characteristics of the study groups, obviously the patients with a left bundle branch block had poorer left ventricular function and worse left ventricular volumes, and obviously scar, which we didn't find in controls by definition. Now, on the right here, you can see the distribution of the myocardial phenotype. So 43% of them had a normal myocardium and normal left ventricular function. The remainder had an abnormal phenotype, and 12% of them had an ischemic phenotype, which actually, when you look into the records of those patients, they had normal coronary angiograms, but nevertheless they had signs of an infarct, and the remainder had non-ischemic cardiomyopathies. Now, HOCM is particularly important here in the same way as aortic stenosis because of the future complexities of managing these patients. So what did we find? We made a very simple analysis classifying patients as to whether they have an MRI, a normal or an abnormal cardiac MRI scan. And if you divide them into that simple criterion, you can see that patients with an abnormal cardiac MRI scan have a sevenfold risk of total mortality, and a greater risk of total mortality or MACE amounting to 13 times. Now, as you know, myocardial fibrosis is important, and there is considerable evidence at the moment to show that myocardial fibrosis is probably superior to left ventricular function in predicting arrhythmic events, not necessarily heart failure events, but certainly arrhythmic events. So we looked at the cutoffs of LVEF of 50% and the presence or absence of myocardial fibrosis, not quantification of myocardial fibrosis, but simply is fibrosis present or is it not present? And as you can see from the left side, the upper left-sided chart here, the risk is much higher in patients who have myocardial fibrosis. The effect of classifying patients as to whether they have an LVEF greater or less than 50% is less powerful, as you can see from those two graphs. And a similar pattern occurs with respect to the composite endpoint of total mortality, or MACE. In multivariate analysis, we find that an LVEF of less than 50% is associated with a fourfold increase in total mortality and a twofold increase in total mortality or MACEs. The important thing, however, is that adding myocardial fibrosis to LVEF less than 50% has a markedly higher risk, almost tenfold risk, of total mortality and a nearly four-fold risk of total mortality or MACEs. So we conclude that amongst patients with an incidental left bundle branch block, no previous history of cardiac disease nor symptoms, 57% have an abnormal cardiac MRI scan. Now in those, total mortality is very much higher. And in fact, in those who have a normal cardiac MRI scan, their long-term mortality is the same as healthy controls. And the healthy controls are very, very well characterized. So we conclude really that assessing myocardial fibrosis and left ventricular function with MR have additive effects on on the risk stratification of patients with an incidental left bundle. Thank you.
Thanks, Paco. That is great. That was very lucid, and I have to congratulate you for such an elegant study on such a common and clinically important subject, because we all know that a lot of patients have incidentally detected left bundle branch block. Now, especially with wearables and eye watches, etc., more and more people are being diagnosed with this condition, and it's important to be able to tell them whether or not it carries an adverse prognosis. And from my understanding of your paper is that of the people who have incidental left bundle branch block, half of them will have MRI abnormalities and half of them will have a normal MRI, approximately. The half with MRI abnormalities will tend to have a worse prognosis than the ones with the normal MRI. And even with the MRI abnormalities, you can look at the LV function and fibrosis. People who have both impaired LV function and fibrosis tend to do the worst of the lot.
Yeah.
So that is quite clear. And I think the take-home message really should be that we should be assessing a lot of these patients who have been picked up to have incidental left bundle branch block with MRI. Is that right?
Yes, I absolutely agree. Yeah.
Okay, so I had a few questions, and I think some of our viewers might have those questions as well. First of all, when you were screening these patients, were these the ones with complete left bundle branch block or even incomplete left bundle branch block?
That's a very good question. So we're very keen not to get lost into the various classifications of left bundle. There are 6 or 7 different classifications, as you know. The most physiologically meaningful is probably the Strauss classification. But when you get into the relationship between the different classifications and outcomes, the literature is very divided. So we took a pragmatic definition of a left bundle branch block, QRS duration of greater than 120 milliseconds with the usual additional criteria. So that actually will apply to most patients with so-called left bundle branch block. In those with a QRS duration of 110 to 120 milliseconds who have a left bundle branch block pattern, so-called in the old literature partial left bundle branch block, we don't know. So having said all of that, I think that probably the same would apply, because if you have an ECG abnormality and then you prove that that ECG abnormality is not associated with an abnormal phenotype, there's no reason why it shouldn't apply to any other bundle branch blocks or indeed any other abnormality.
Probably that would be a very nice subject for your next area of research, perhaps your
Yes,
next.
absolutely.
And the other thing which I was struck by was that you looked at categorizing the MRIs in terms of scarring as well. So just not merely an accurate assessment of LV function, but also a careful assessment of LV scar. And according to your study, that provided additive value over just LV function assessment.
That's right. And we see these from other data sets that we're working on and that we have worked in before, but we know that an ischemic distribution of scar is very predictive of arrhythmic events, actually, and characterization of the type of scar, gray zone, etc., adds additional value to that. In this study, we wanted to be relevant to any hospital, not get lost in the quantification of scar, etc., but simply say there is scar or there isn't scar. And we show that simply that rather heuristic approach in categorizing scar works in clinical practice.
Okay, so now you have a subset of patients with left bundle branch block whose cardiac MRI has shown abnormalities, so you know they're at higher risk. The question is, what next? How do you think we should manage them? Do you have any idea as to what was the main reason for this excess mortality? Was it sudden cardiac death? Was it heart failure?
There was a minority of sudden cardiac deaths, and there were pump failures. There was also all non-cardiac deaths, actually. And the reason for that, I think, is because this is a retrospective study in patients who are coming into hospital and they get picked up for maybe other reasons. In fact, in those non-cardiac deaths, there were 5 patients who died of cancer. And there was an overdose and there was other unrelated deaths. But I think that this is just a reflection of the fact that this is a real world study. And obviously, if you do cardiac MRI scanning in people who are attracted to the hospital for any reason, you're going to see more non-cardiac deaths. But yes, I mean, in terms of cardiac problems, there was certainly an additive effect of scar. And that was mainly with respect to the major adverse cardiovascular events, not necessarily heart failure events.
Okay. And finally, a more pragmatic question. In my hospital, if I put in a request for a cardiac MRI, I'm looking at 4 to 6 weeks wait, right? If we start screening everybody with left bundle branch block with cardiac MRI, the MRI scanner will be full of just these patients. So how do you plan to get around that issue?
So, I mean, if we go into the field like cancer, for example, and you have an ambiguous result from a cytology screen for a cervical screen, you would be expected to have a great deal of investigation, including a further biopsy, CT, staging, etc. Now, these patients who have a positive cardiac MRI scan have a very poor prognosis. We're looking at 10 times the risk. This is very serious, really, for those patients who have a positive cardiac MRI scan. So whilst I agree that the availability of CMR is difficult in some centers, I think we should use papers like this to perhaps justify the availability of this technique in saying to people, look, actually, it's cost effective, because if your cardiac MRI scan is normal, we don't need to follow you up. And that's half of the patients. So actually, you can make it a very cost effective procedure.
Hopefully, scientific guidelines will make it easier for practicing cardiologists by introducing these recommendations. And hopefully, if your study results are replicated by other groups as well, then in a few years' time, these might be standard guidelines. Patients with left bundle branch block should have cardiac MRI scanning to triage their risk.
Yes, I agree.
Excellent. Well, thanks very much, Paco. That was really, really useful. I, as an electrophysiologist, learned a lot from reading that paper and listening to you. And I hope some of our listeners and readers have had the same feeling as well. Thank you very much.
Thank you, Dhiraj.